Good afternoon. This is Jan Attard. Today, we're going to be having a dynamite and exciting discussion about something that I'm very passionate about, and hopefully everyone can learn from. So I am just praying that you stay on board from beginning to end, because we're going to be discussing the new, not quite so new, eighth edition recommendations to neonatal resuscitation and why the American Academy of Pediatrics guidelines, not that they are code, not that they are law, but specific guidelines that are nationally rounded upon best practice standards for all babies at delivery, um, and nationally recognized, and something that I take very seriously as an instructor of NRP. I think right now I could say that I have done this for over 22 years, more like 24 years, and I act as an independent instructor, sort of at the drop of a hat. And through COVID, we learned how to get it done. But I am honored by the following that I've had and the amount of people that I've been able to teach. So this is for students, for nurses, for anyone, doctors who want to listen, anybody interested in learning more about NRP and the importance of, as Ian, my son, would say, Mr. Sopa, Mom, when are you going to teach Mr. Sopa again? The importance of airway, the importance of airway over cardiac. For you and me, it would be cardiac. Our heart is something that will probably go first as we get older. But for the baby, you get air into the lungs, you increase the heart rate, and that baby will survive. So it's the quick, efficient actions, knowing risk factors, that's going to make a difference. And that's what we're going to discuss today, and why each and every nurse knows these guidelines. Each and every nurse knows the standard of care, like the back of their hand, and they can do it second by second. It's not minute by minute, it's second by second. So let's get started because there's a lot to cover. Okay, so I'm not going to read from the screen, but I am going to go over everything carefully. If anyone wants to contact me, please do. You can just look me up, Jan Attard. I can be found doing NRP pretty much all over the place. But I look forward to your questions. I look forward to anything that you have for me, that you would like me to discuss. So today, we will review the changes of NRP, not only in the United States, but in Canada. We will go over the timing of the implementation at delivery. Why is timing so important? The science that underlines everything that we're doing, the ethical and legal guidelines, administrative and educational changes, why it's so important now based upon code, based upon law. Different states have different standards, but down to A1, down to American Academy, why it's so important for best practice to level up and have different levels of NICUs based upon the age and the birth weight and the risk factors and the presenting scenario of each baby. This is all designed with quality, safety, and risk in mind, because we want best practice outcomes. We want babies to live and thrive and do good. Otherwise, if they're not at the appropriate facility, we're going to stabilize and transfer if we possibly can. So we're going to look at this screen. Hopefully everyone can see it. And hopefully, I'm going to say that some of these resources that I am using are taken not only from the American Academy of Pediatrics, but a variety of sources. So in conjunction with myself and what I'm utilizing, hopefully I can teach, and we all learn. And that's really the goal, that we all learn. So in the course of 1 minute or less, that baby comes out and I am eyeing that baby and I am intervening immediately. So First of all, we want to know risks and what are they before the delivery. I'm going to make sure my equipment is ready, my machine is on, my blankets are warm, I have my ET tube ready, I've got my Neopuff ready, I've got my suction ready, I've got my stethoscope, and I am ready to go. I've set my settings at the right setting. And then I find out, okay, what age is this mom? Has she had previous babies? Does she have complications? Has she had hypertension? Does she have gestational diabetes? Are we dealing with a situation where there's meconium? Are we dealing with a big baby because of maybe gestational diabetes? And considering the potential of a shoulder dystocia? Are we taking a look at the fact that the mom has choreo? Maybe she's got a fever because she's been in labor a very long time. Is there GBS positive, group beta strep positive? All these things we're going to take into consideration. Is there meconium? Maybe I already said that. But we're looking at everything because NRP standards say if we have more than one risk factor, we are going to have at least 2 qualified professionals at the delivery capable of resuscitating, meaning not only resuscitating, but intubating and providing the kind of support to any baby, any delivered baby who comes out breathing and responding. Now, when I went to Georgetown, viability was 28 weeks. And I remember that very, very well. Okay. Now, okay, I'm a professor part-time, an adjunct professor. I also work in Berkeley, California, but I'm also an adjunct professor. And recently we have babies born viable as low as 21, 22 weeks. So it's all based upon knowledge of risk, knowledge of intervention. How are we going to intervene? So in that first minute, we're looking at term. Does the baby have good tone? Is that baby breathing or crying? If the answer is no, okay, we're going to intervene immediately, okay, to warm, dry, stimulate, position the airway, and suction if needed, because we need oxygen going to the brain. We need blood circulating through the body. This has to happen very, very quickly. And nurses in my position, ALS nurses, neonatologists, pediatricians, they know this and they do this like the back of their hand. However, if that baby comes out pink and breathing and looks fabulous, of course, we're going to leave that baby with the mom. Bonding, delayed cord clamping, 30 to 60 seconds, get that baby to the breast, hand express colostrum. It's magical just as soon as we can. However, before, 15 seconds in, take those vital signs. If it's a minute and we still have an apneic or gasping baby, what are we going to do? We're going to suction, reposition, tell the doctor, instruct the doctor, please cut the cord. It is our legal responsibility because the doctor's focusing on the perineum to say, doctor, please cut the cord. I need the baby over to the table. Labored breathing, persistent cyanosis, we need to take action, especially if the baby came out with a nuchal cord, meaning the cord was wrapped around the neck 1 time, 2 times. That baby was swimming in circles inside the mom. We need to take action to make that baby pink, to get that baby pink and breathing and circulating. Why? Because we need the heart rate greater than 100. These babies that come out depressed, not breathing, blue, we need to intervene, okay? And that needs to be done quickly. You don't just let them lie there, you intervene. You want that heart rate greater than 100. If it's not, you have decreased circulation to the brain, decreased oxygen moving around. So at that 1 minute mark, hopefully we've got the heart rate greater than 100. Hopefully we've been successful and we can get that baby right back to the mom. That is our success story. Those are our happy babies. That happens all kinds of times where we have to stimulate and then get the baby right up to the mom. It may seem a little traumatic to the family, but we do this so quickly that oftentimes they don't even know what's happening. The most important thing is we act, okay? So why? Because we want adequate ventilation. We're going to intervene. And if the heart rate is less than 100, okay, the actions are head in a sniffing position, start to ventilate with a neopuff, okay? 40 to 60 breaths a minute, making sure that we've checked the airway. Do we need to suction? Do we need to use 80 to 100 millimeters of water pressure to make sure those babies with lots of secretions, we've cleared it out, okay, to ensure adequate ventilation? We're not going to consider an ET tube or laryngoscope mask right away. That happens if the heart rate falls after a full 30 seconds of positive pressure ventilation that moves the chest until the heart rate drops below 60, okay? But we're going to do our first 30 seconds, making sure that everything's fine. Get that baby to the table for the next 30 seconds. Intervene and dry and stimulate. Start PPV if we have to. If we're not getting adequate air exchange, do what's called Mr. SOPA. What do? Open the airway, increase the pressure. At the end of the day, the goal is expansion of the chest for a complete 30 seconds. If after that, you've got a baby with a heart rate less than 60, okay, then, and it's less than 60, and you've had those 30 seconds of positive pressure with ventilation of the chest, then and only then is a time where you say, okay, we're going to commence compressions to this baby. Increase our oxygen. We started on room air. In the olden days, we started with 100%. Now oxygen is considered to be a drug. We start at room air. We go up to 100% if we're going to start doing compression. And then it's like ballet. You do a coordination of 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. And I don't have a baby with me today, but I will back this up with a video to show you exactly what I'm talking about, okay? The most important thing, like I said a few minutes ago, circulation to the brain, oxygen throughout the body, decrease the incidence of any kind of damage that might happen. There's the reach elevator, helicopter, not elevator, right there. My friends are up there, either getting a baby or transporting a baby. It is a very small world, and it is a wonderful world. And when you save a life, it's not an adrenaline rush, believe me. But it is bonding with a family like you never thought you could. Bonding with a family because it's the honor of being there to serve. Bonding with a family that makes such a difference, that it makes my life worthwhile and valuable. And I've done this for 40, going on 50 years, and I still want to do it. But now I want to teach you, and it's so important. So if you need to learn and I'm being too quick or too unclear, you just contact me and we'll take ourselves through it, okay? So at the time of delivery, that beautiful baby comes out. From the second the baby's born, we don't have to have oxygen saturation of 100%. We don't, okay? Minute number 1, 60 to 65. Minute number 2, 65 to 70. Minute number 3, 70 to 75. So the standard of care, truly, policy and procedure, truly, American Academy of Pediatrics, gold standard. People are going to say, wait a minute. The code says, administrative code, the law says, wait a minute. But I'm going to say, yes, the law is paramount. But the gold standard of the American Academy of Pediatrics, and you can call me on this, you can reach out to me on this, is best practice. If it was your son, your daughter, your granddaughter, the child you were caring for, you would want to follow the tested guidelines of the American Academy of Pediatrics, okay? To follow exactly what has been tested as best practice within hospitals. Let's move on. Okay, so essentials, basically what I said before. We're going to start out and we're going to make sure we have good equipment. We're going to make sure we ask all the risk factors. We're going to make sure, number one, we're prepared. Number two, advanced practice nurses are ready to provide positive pressure ventilation. We've got somebody capable of intubating. We've got somebody capable of putting in a UVC line in case we need it. And we act. And the first minute is the most critical, okay? So again, 3 questions: term, tone, breathing or crying. Stay with the mom, gold standard. No, okay, that baby is grunting, that baby is not breathing adequately, or that baby's not breathing. So big hands, dry and stimulate, position, suction if needed. Maybe we don't need to cut the cord right away. If that baby is gasping a little bit and we think that we can do a bulb syringe and get the baby suctioned, maybe we can do that and get that baby's heart rate greater than 100. If it's like 90 and climbing, then we're going to leave that alone. Okay. But no, if that baby has labored breathing, persistent cyanosis, my dear friends, we need to act. Okay. And we need to get that cord cut. We need the baby over to the table. We need to position, suction, and immediately start either PPV or CPAP, whatever we need to do to open up that airway, to get oxygen stimulated, circulating through that body. Okay. Because what do we need? Heart rate greater than 100, blood circulating around the body. Okay. Decreased chance of brain injury. Okay. Decreased chance of brain injury. Ensure adequate ventilation. Later on, after we've done that 30 seconds of PPV that moves the chest, okay, if our heart rate is less than, what did I say, less than 60, maybe then, only then, we're going to consider doing compressions, okay? But this is a team effort, a team collaboration. There's not one person doing it. Normally, there ends up being 5 or 6 or 7 or 8 people in the room, including respiratory therapy, including neonatologists, including pediatrician, including, charge nurse, including head ALS nurse, including everyone else who is into documenting, is into record keeping, is into time management, is into providing equipment, medications. If somebody's not performing the skills of positive pressure ventilation adequately, your best friend doesn't stand there and say, I don't want to make him feel bad. They say, Jan, you're not providing that well enough. I'm going to step in and do it. So nobody has an ego. Nobody has an ego. We just step aside. This is like probably for a lot of us, the most comfortable place we could ever be in. In that room with that mom who's worked so hard and that dad who's crying. And it's just standing over you saying, please help my baby. And your team that is backing you up, or you're backing them up, and that beautiful baby. And you've got 1 minute to act. So we're going to prepare. So again, we have a briefing. What does the briefing consist of? It's knowing what are your risk factors. So again, I've already said this. I'm going to repeat it again. Okay. What is the gestational age? So 40 weeks is gestation of a baby. That's when they're supposed to come out. Well, these days, whether it's COVID related or not COVID related, whatever it's related to, babies are being delivered so much earlier. So not uncommon for babies to be born 36, 37 weeks. We used to call any baby less than 37 weeks a chicky baby. That meant they were requiring extra special care. Now, babies can come out 36 weeks, 37 weeks, 35 weeks. And depending upon their weight and how they do, they can actually, some of them can go to the floor. They don't have to go to the NICU right away. So it's all based upon, the measurements of the weight, how the baby's acting, okay? So what are our 4 pre-birth questions? Gestational age. And of course, As they go above or below 37 weeks, it's going to be higher or lower risk. Is the airway clear? Is there meconium? Okay. What is mech? Mech is poop. The baby poops inside the mom because the baby is stressed. Whether the cord was around the neck, whether the baby was stressed. Any additional factors that are risk? What are they? Gestational diabetes, hypertension, drug presence, no prenatal care, and the umbilical cord management plan. That's a new one. That's why they have it highlighted here, because that used to not be on the criteria for 7th edition, but it was added because they find that it's so important to have, quote, delayed cord clamping. Why? Because we have a pulsation of the umbilical cord. What does that do? Pulsation adds oxygen. Pulsation moves blood. We're allowing these babies to have more time, more blood to circulate through the body, less chance of injury to the brain. So really, really important. If we can do delayed cord clamping, we will. In the olden days, okay, whether we had a baby with risk factors or not, a lot of times what they would do, what you'd see them do, is they would milk the cord, okay? So they would milk the cord to move the blood faster into the baby, but we don't really do that anymore, okay? So we're careful to just try to allow, okay, the blood to pulsate on its own. Yes, so the golden minute is what we call it. It is a fantastic time allowing that baby to, quote, transition. What is the word transition? Gosh, I'm going to share this tape with all of my students down at Stanford and all of my students at USF and all of my students at Samuel Merritt and Cal State. Anyway, lots of learning for all of us, okay? So the first minute, again, we're going to go back to the first minute. What does it mean? Again, we've counseled ourselves. We've counseled the team. We know what's happening. We looked at the prenatal history. We've had a team briefing. We know what the risk factors are. We know how far along she is. We're watching the prenatal strip. Are there decelerations? Is everything going good? We've checked our equipment. We are prepared. We are ready, okay? So again, same question. Term gestation, good tone, breathing or crying. If we have a very early term baby, what are we going to do? Especially if this baby is less than 32 weeks. Well, our alarms go off. Alarm, 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 okay? Especially if we're only a level 2 nursery. Because what? What does NRP say? What does the American Academy of Pediatrics say? Well, this must have been or might be an emergency delivery. OB didn't know that it was 32 weeks or less than 32 weeks. Maybe the woman just walked into the hospital and we've got an issue. Yes, can babies be born at a level 2 nursery that are less than 30? Of course they can. They have to be. We want to resuscitate and we want to stabilize. But the baby is delivered at a level 2 facility and the baby is truly less than 32 weeks or less than 1,000 grams, truly the resources that are required by the majority of babies in that age category may need surgical intervention or consultation, may need more respiratory support or film watching than a facility with a level 2 can provide. So we, the professionals that work in these facilities and have no ego on a regular basis and know the importance of a neonatologist in-house all the time and equipment present all the time, know how important it is. So back to my thing, if the baby is less than 32 weeks, we're going to try to stabilize that baby, by golly. stabilize, and transport. Okay. So nothing more need be said about that. So back to the 1 minute. Okay. Term, tone, breathing or crying. Yes, we stabilize, we do some drawing and stimulating, and the baby stays with the mom. Conversely, poor tone, not breathing, dry and stimulate, cut the cord, over to the table, positive pressure ventilation at a rate of 40 to 60 breaths a minute that moves the chest and gets the heart rate raising. Bravo, bravo. You've done your good job, not you as a team. Okay. Your whole team shows up. Jan, do you need any help? Oh my God. And the family says, thank you. Now, sometimes those babies breathe in, suck in secretions, and they end up with some retractions or some grunting. We take them to the transition nursery, where the doctor authorizes the delivery of CPAP to open up those arterioles. Sometimes we take a chest x-ray to see that there's water down in the bases of the arteriole. Well, what would that cause? Well, if it was there too long, possibly infection. So again, minimize labored breathing, get rid of persistent cyanosis, gradually over time, minute by minute, increase the oxygenation to the baby. Oxygen to the brain, oxygen to the vital organ. Decrease any chance for seizure activity. Positive pressure ventilation, put on that pulse ox. Put on ECG leads. You know, that's like candy in the candy shop. If we have those devices, we put them on because we want to make sure we can document second by second what we did and what are our interventions. Who did we call? Who did we report to? I want the charge nurse. I want the neonatologist. I want the MD. I want the pediatrician. I want everyone. They can always leave. And we're not dictating. As nurses, we are professionals who care. We are professionals who know how to, we're the eyes and ears. And so we're there to facilitate everything on behalf of the team. And the doctors come in. So we position the airway, we suction if needed. We do the pulse ox, and we consider CPAP, and we're lucky. So ventilation is key. So again, like my son, Ian, come on, Mom. When was the last time you taught Mr. Sopa? So Mr. Sopa, open the airway, increase the pressure, make your changes. Why? Because we want oxygen to the lung. Okay. If there's no heart rate increase and no chest movement after 15 seconds, we're going to do our Mr. Sopa. If our heart rate continues low despite ventilation, then and only then, after 30 seconds of positive pressure where you've moved the chest and the heart rate is still low, then you're going to put in an ET tube. You're going to do that first before you commence compressions. So airway first. Okay, airway first, Mr. Sopa first, if your saturation targets are unchanged. So back to the left, apneic or gasping in a heart rate less than 100. Okay, start PPV, put on your pulse oximeter, and consider a cardiac monitor. Heart rate still under 100. You're ventilating, you're considering putting an ET tube or a laryngeal mask, whichever works. And ET tube is quick and fast, but if it doesn't go in easily and you don't get the expansion of the lungs, you may consider a laryngeal mask. And then, of course, the cardiac monitor. You need to act fast. You need to get circulating blood. Because if our heart rate still drops, okay, we've put in our ET tube or a laryngeal mask. We've commenced chest compressions, coordinated with 100% PPV oxygen. And at that point, because we have a heart rate less than 50, we're going to be putting in a UVC line and thinking of giving epi. In the olden days, there were lots of drugs we would give, including Narcan. We don't do that anymore. We just do epi and volume expansion. Epi is given every 3 to 5 minutes if the heart rate remains less than 60. We're going to consider hypovolemia, which is lack of fluid. Maybe the mom bled out. And we may consider a pneumothorax if the baby's just not being ventilated adequately. So again, 30 seconds of PPV versus alternative airway. Chest compressions at the heart rate less than 60 at a ratio of 3 to 1 and 100% oxygen. And if no increase in the heart rate, we're going to do cardiac compressions. And then after 60 seconds, and the heart rate is still less than 60, we're going to consider epinephrine. Quick. Okay, everything quick. Epi can be given IV or interosseous. Dose is 0.01 to 0.03. And we're going to suggest that the initial dose is 0.02 milligrams per kilogram. And the ET dose is different because absorption is different, 0.1 milligrams per kilogram. And we're flushing. This is new for the 8th edition. We're flushing with 3 cc's of normal saline. And we can repeat every 3 to 5 minutes if we're not seeing any kind of benefit. So normal saline remains the expander of choice. Packed cells in case of fetal anemia. And then we're going to consider other causes if the patient's not responding, including a pneumothorax. And the reasonable time frame considering cessation of resuscitation. Now it's been changed. It used to be 10 minutes. And now there is literature in the RNC, the nurse certification guidelines and literature, that say that there have been resuscitations for 20, 30 minutes that have been successful. So we always review science underlying the recommendations as an expert. We don't just give guidelines to give guidelines. We review everything we do, and it's based upon great research of repeat incidences and outcomes. So I honor everyone I work with. I honor all the people that are present at every delivery. And where I work, we have 600 to 700 babies born each month. Although the majority of babies that are born gorgeous and healthy and stable, and sometimes they're not. And so for those of us that do this work and care and strive to always give and give back and hold a baby and love a baby and nurture a baby, and make sure we can put that baby in the mother's arms to be breastfed and held and loved, we act. So cord clamping, what they say, and this is also a recommendation for 8th edition, it is reasonable for both term and preterm infants who do not require resuscitation at birth to have delayed cord clamping for 30 to 60 seconds. And why is the reasons I've already given. Circulation of oxygen to the brain. If we have to do PPV, positive pressure ventilation, we need to cut the cord because the infant has to be brought over to a warmer, to be looked at, to be monitored, and all the other interventions. So We're not going to talk about this. We talked about epi. We talked about epi. We talked about epi. Um, this is a difficult subject because I'm luckily have not been privy to this, although at our hospital it happens. And the difficulty would be stopping because one would want to just keep going and going and going. But in recent years, long-term outcomes for survivors requiring prolonged resuscitation have improved. Amazing. Okay. So back to what we were talking about, focusing on team and QI considerations. QI is everything. Okay. So again, basic steps that we've gone over. 8th edition, 4 pre-birth questions, initial steps, alternative airway before compressions. Why? Maximize the opportunity to expand the lungs. Do it fast. You have 30 seconds and then 30 seconds, and you better be on your way to intervening if that heart rate is less than 100. You're only going to give epi if you've tried and you have a heart rate less than 60 and you've already done your 30 seconds of positive pressure ventilation that moves the chest, and you've put in your ET tube and you've started to do chest compressions and your oxygen is at 100%, you're going to consider epi only at that time. You're going to just keep on going. So as a whole, okay, I'm not going to get off this page. I will stay on this page. I think that the most important thing that we do is act. There will be tapes that will follow this up. I really am honored to teach and mentor all of this. As you can see, there have been changes over time, and good changes. We started with 100%. We started with room air. No, we started with 100% and now we use room air. Okay, we started with 10 minutes and now we're up to 20 minutes. Basically, those of us at the bedside, we act, we intervene, and we help you to learn what you want to learn about acting and intervening. So thank you, and any questions, please contact me. I'm Jan, and you know where to find me. Have a great day. Bye now. Thank you. Bye.